I'll start off and show a few cases since I've been gone. Let's see here. Hopefully this works. So this is an interesting case, and I would love to know what you two think about this case. I wish Seth were on too, because he may have seen this. So this is a patient with myelofibrosis, a history of essential thrombocytosis, and antiphospholipid antibody syndrome. And they were getting a CT as part of their pre-bone marrow transplant because they're sort of developing a leukemia type picture. And they do these routinely here before myeloablative therapy to look for infection, and rarely do we ever find anything of interest. But what I noticed on this scan, as I start going down, look at the periphery of the lungs, particularly in the lower zones, and look at the arteries. You'll see like this one is big. And as I go down, it gets more and more impressive. All of these peripheral vessels are getting big. They're not nodules, they're not veins, they're all arteries. See all these big ones here. You can see a couple out here as well. And I had no idea what to make of this. It has a normal echo. And I don't know if it has something to do with the thrombocytosis from years ago, if it has something to do with antiphospholipid antibody syndrome, or if it's just something unexplainable.
I'm not sure, Jeff, that I would have called that or perceived that as being abnormal, just scrolling through it like that.
So let me show you an area here. So if you follow this vessel here, we follow it down, you can see it gets a lot bigger. And look at all of these. I mean, it almost looks like a hepatopulmonary syndrome, but the patient has no liver disease. See all these little telangiectatic vessels this far out.
I don't know. What that would be.
It's just a curiosity. I didn't know what to do with it.
Yeah.
Clearly the patient
I don't know.
symptoms. David, have you ever seen anything like that?
No, but I do. The first thing I thought of was hepatopulmonary syndrome, and then I recall a case that we had here. It was a young guy who had some syndrome, and he had what looked like florid hepatopulmonary syndrome, and he was hypoxemic. And he, his CT findings were even more dramatic than this case, but there wasn't any history of liver disease in him. So I think there are other ways that you can probably trigger that, that vascular dilation or something like that.
Mm-hmm.
So maybe something released by all those platelets or something like that has remodeled the vasculature in this guy.
That's what I wondered, if it had something to do with his earlier hematologic issues. But
right.
Yeah, I don't know.
Is he anemic currently?
Yes, he is.
And so I wonder if it's a kind of, maybe it's a high output pulmonary failure, high output heart failure sort of syndrome with his anemia. His heart's not really big, is it?
No, it's normal.
Okay.
Yeah, so he was having no symptoms. I don't know. I figured it was probably related to that, and I found a case report for like idiopathic, which whatever that's worth.
Got it.
Okay. Now here's a case I'm more sure about. So this is just a really nice example of the value of expiratory imaging for central airway collapse. So this patient has obstructive physiology, and you can see the trachea is normal for the most part on inspiration. The lungs are fairly normal. I think there was a cyst and there's a little bit of heterogeneity, but nothing you get excited about. But on forced dynamic or end expiration, you can see there's a little bit of air trapping in the basis, but what's quite striking is the collapse of the main bronchi and the trachea here, the frown sign that Phil Boisel coined. But you see the cartilage itself is intact. So this is a nice example of excessive dynamic airway collapse, or EDAC, that you can completely walk by on inspiration. So back to inspiration, you can see. Put them up side by side. So that was one of the more impressive ones I've seen.
Jeff, it's EDAC?
Yes, excessive dynamic
Makes it-
airway collapse. So the
Well, I'm
difference
sorry.
is with tracheomalacia, the cartilage itself is weakened, and so often it splays on even on inspiration, or it's sort of this lunate shape. Whereas with EDAC, it's a weakness in this posterior membrane, which does not have cartilage. And it could be from muscle weakness, it can be from deficiencies in fibers, chronic obstructive lung disease, but they both present with that central expiratory obstruction. EDAC's a little easier to treat. They usually do a stent trial first, and if that improves it, you can do a tracheoplasty where they buttress this membrane with like a mesh support, and that prevents it from collapsing down. But they'll do the stent trial first to make sure it actually patient has better improved PFTs and symptoms. Whereas with malacia, you can't really repair the trachea itself, and sometimes they require stenting, which is not great in the trachea. Speaking of airways, here's another just really nice example of a patient who has a history of granulomatosis with polyangiitis, chronic sinus disease, and chronic kidney failure. And this was just done as part of a renal transplant workup and question of some lung nodules. But if you look carefully, you can see there's narrowing of the trachea at the level of the thyroid. It's a little irregular. And then as I go down, you'll see the wall's a little bit thicker than normal. And then further down, right here at the carina, you can see it's irregular, it's thickened, and it's thickened posteriorly, and then extends to the main bronchi. And on the lung windows, you can see the stenoses, which is kind of cool. And there's even a little web here in the left upper lobe. And so a little bit of air trapping out there. And then this was the nodule in question, which is probably a scar from an old GPA lesion. But this is one of the more extensive airway cases I've seen. Often it's subglottic and patchy, but this one was a little bit more. Since we've got, who else is on? I think we still have a lot of time. So I'm going to show these last two cases. So this is a patient who presented with a spontaneous pneumothorax or hydropneumothorax. Looks like an elevated hemidiaphragm versus some other abnormality there. So got a chest tube, and then they did a CT at that time. And what you'll see is there's a small effusion at that point, but there's this really dense consolidation in the middle lobe, in the right lower lobe there, and you can see this pleural thickening and some ground glass around it. But the patient wasn't having any signs and symptoms of infection at that time. So now we got to think about other causes of consolidation. You could think about a malignancy, you could think about organizing or eosinophilic pneumonia. So the cytology on the pleural fluid actually showed extramarginal zone B-cell lymphoma. So this is all lymphoma here. Some of this is rounded atelectasis, but I suspect there's probably a little bit of lymphoma in there as well. But I've never seen it involve pleura. I've seen it, we've seen those malt lymphomas in the lungs, and they could present as masses or more often nodules with usually fuzzy margins like this. But I've not seen it cause pleural effusion, and why there's a pneumothorax, I don't know.
Oh,
So Jeff, was there lymphadenopathy and maybe lymphatic or venous obstruction? Nothing like that.
No.
No, the meat
really
looks pretty good.
Yeah.
Yeah.
I guess it just invaded the pleura from the
Yeah.
lung. You can see it's kind of a little more nodular there, and then it just spilled into the pleural space.
so they found lymphoma cells, and they were able to suggest a particular lymphomatous pathology.
Yeah, they
just
did all the
based on
usual
the cells only.
fancy hemopathology stuff.
Because you can get so-called primary effusion lymphoma, but I think typically in that circumstance, you don't get large pulmonary opacities in the lung.
Right.
It's a pleural space process.
Right. I think this is lung that extended into the pleural space rather than the other way around. And I think the type you're talking about is often associated with like chronic empyema.
Or it's one of the HHV syndromes,
Mm-hmm.
like Hasselman's.
And then you're going to like this last case because I know you both like the diaphragm. So this case, if you look at the radiograph, this looks like pleural plaque. I think this was reported as pleural plaque. I would have reported as pleural plaque. But it's a younger patient, and you'll notice there's a stent here. Patient has chronic kidney disease. And on the CT scan, you'll see there's no plaque anywhere else. And if we get down here, this is a little unusual for plaque in that it's covering the entire dome of the diaphragm. And if you look carefully as we get further down, you'll see it's actually calcification of the diaphragm rather than pleural calcification sitting on top of it. And what I think is convincing that that's what's going on is there's also capsular calcification in the spleen, and I think there's the kidneys there. And I was wondering if this is related to the renal failure, if there was previous peritoneal disease or peritonitis or something, maybe something with the spleen. But when I started looking at this, I was convinced that this actually was not asbestos plaque, but rather, let me make that go away. I hate this new pop-ups. I get these all the time. If we look on the sagittal, you can see that it actually is in the muscle slips of the diaphragm.
Wow. I don't recall ever seeing that before. Symmetric diaphragm muscle calcium.
Can you scroll across to the other side, Jeff?
Yeah, here's on the coronal.
So it's interesting. It's in the fibrous part of the diaphragm rather than the muscle. It's where the tendon is, not where the muscle is, and that would fit with its being in the capsule of the spleen. It's really in the fibrous tissue, not the muscle.
Okay.
Very interesting.
The central tendon. And how are we connecting it with the splenic calcium?
Well, I wondered if there was some sort, because I couldn't find any trauma history, if this is some sort of like peritoneal process. I don't know if the patient had had peritoneal dialysis in the past and if it was just sort of like a chronic peritoneal abnormality, except I would like to see it somewhere else in the peritoneum, but I don't have an abdominal CT. Or it's just dystrophic calcification from chronic kidney disease.
Very odd.
It is very odd.
Never seen that before, such a thing.
So you said it was a peritoneal dialysis person for the chronic
I don't
kidney?
know. That's the thing. I don't know if it's peritoneal dialysis or if it's. I just know that all I got was they were referred here for a kidney transplant workup, so I had like no information.
And no calcifications around the shoulders or anything like that. That sort of classic.
No, I can show you.
Pleural calcinosis thing.
No, it looks pretty normal up there. Just a lot of vascular calcification.
And very odd.
I think these are pseudoplaques of Jeff.
They are definitely pseudoplaques. But yeah, I mean, going back to the radiograph, other than the extent of them, usually pleural plaques aren't that long. If you just had the frontal radiograph, I mean, if I were taking the B-read exam, I would have scored these as plaques.
Yeah. And the other interesting thing is that it's not diffuse pleural thickening because the costophrenic angles are not involved.
Right.
And it's very localized and very clean looking.
Yeah. And
okay, it's a mystery.
Be very real plaques in a young person. Okay, well, that's all I have this week. If one of you wants to go next.
I would like to try again, Jeff. I was unable to show stuff with my new, operating system last week. So to see if I've cracked the security.
Yeah, usually you have to grant a permission and then you have to restart GoToMeeting to make it work.
Do we have an image?
Yep, we do.
Okay, so the flu season has started, and this 28-year-old has this presenting radiograph here with some mild patchy consolidation in mid-lungs, left a little bit worse than right. And this is influenza A, which is definitely it's capable of being more severe than influenza B. So here it is just a day later. You can see this dramatic progression here. He's now intubated, and then becomes even more diffuse. And at this point, he now is on ECLS, so he's requiring a lot of support. And the current radiograph shows even more lung consolidation. Now, Howard's talked about the lungs, being opacifying just in the presence of VA ECMO. So that could be what's going on here, contributing to the lung disease caused by influenza itself. But you can see this is a really severe course in this young man, just 28 years old. He's also had a few little catheter adventures here with this left arm catheter crossing the midline and looped into the jugular vein on the right. So influenza's here. Just had a case of RSV this morning in a person with graft versus host disease who was immune compromised. And the interesting thing about that, which I don't have ready to show you, is that there was the upper lung ground glassy stuff. It was fairly sparse. And his cough was initially a dry cough, a very persistent, angry cough, and then eventually became productive. The CT scan that we has shows the mild ground glass abnormality attributable to the virus in the upper lungs, but in the bases, I think there's a lot of aspirated crud that's contributing. So there's a lot of peribronchial dense consolidation that I think is more of an aspiration of phlegm and things like that from above rather than a separate process or something attributable to the virus itself. So I think with these viral infections, we saw it in the influenza and in the COVID era, that you would often, if you caught imaging early, you'd see upper lung predominance, but then you'd get worsening of the bases over time. I think that's probably secondary rather than primary viral process. At least that's my supposition. Okay, let me show you a person here with a bad roll of the dice. So this chest radiograph shows pretty normal looking lungs. There is a little pneumothorax problem here and a little fluid level down here. So it was a hydropneumothorax. And let's check out on CT and see if we can find out why there might be a pneumothorax. It turns out that this person has cystic lung disease. You can see some of these cysts are perched on the pleura here, ready to pop and lead to things like pneumothorax. So this woman has cystic lung disease, and it goes all the way down to the bases. So it would fit with lamb. Let's go on into the abdomen. So we see this bizarre set of staples here in the liver. That's kind of weird, and a bunch of lucencies in the liver. And then these very big abnormal kidneys here with lots of cysts. Okay, so this person has cystic lung disease. And I don't know whether this person also had any neurological conditions. I don't have a head CT, but this person carries a diagnosis of tuberous sclerosis and also of polycystic kidney disease. Now, I'm not sure I'm going to be able to show you an abdominal CT from earlier, but this is a person with contiguous gene syndrome. This person has both adult polycystic kidney disease and tuberous sclerosis. So how, you ask, would a person end up with both these things? Because this is a reported combination. And it turns out that, let me show you the last page of this. It turns out that both the tuberous sclerosis gene 2 and the polycystic kidney disease 1, these genes are on the same chromosome, number 16. And so it's possible that a deletion, they're actually back to back, they're tail to tail on that chromosome. And so a deletion of that area can result in both of these syndromes occurring together. So this person had an angiomyolipoma in the liver, and that was resected. That's why there was that thing in the liver, that staple line in the liver. But the person had also had a angiomyolipoma in the left kidney, which disappeared on subsequent imaging, but I couldn't see signs that it was resected, so it might have regressed on its own. Or they might have, I don't think they resected at the same time that they resected the liver angiomyolipoma. So this person had two kinds of kidney lesions, the polycystic stuff and the angiomyolipoma, and had lung cysts and has had hydropneumothorax as a result of popping the cysts. Have you guys heard of this combination of genetic diseases before?
I don't think I've seen one, but I think I've seen a report, if I remember correctly, of polycystic kidney disease with cystic lung disease. And perhaps that patient has this entity which wasn't diagnosed as this combined entity at the time. But one can find case reports of otherwise unexplained cystic lung disease in patients with polycystic kidney disease.
I think we've now explained it.
Yeah. I've got one case,
TS,
polycystic kidney disease with this, but I wonder, I have to go back and look at it and see if they have a lamb distribution.
Yeah. So there's another TSC gene, TSC1, which is on chromosome 9. So the one that's involved in this contiguous gene syndrome is TSC2. So it turns out there are other examples of this contiguous gene syndrome that involve some other syndromes occurring together. It's very strange, but once you understand the genetic mechanism, it's explainable. Now let me see if I can pull up the, I'm going to quit this. I don't think I'm going to expose any information here, but I'd like to show you the angiomyolipoma in this same person here. So that was the 2017 exam. Okay, so here's the abdominal CT from outside. We have the cysts in the liver, and we have lots of cysts in the kidneys. And as we go down to the bottom of the kidney, we come into a big fatty mass down here, sort of hanging off the bottom of that kidney, sort of exophytic. Sudhakar told me that the angiomyolipomas can be exophytic like this one. So I don't think this is just adjacent fat. I think that this is a fatty tumor from the lower pole of that kidney.
There may be one on the other side, maybe.
Think so? Yeah, that's right.
I can't tell. Oh, maybe.
Yeah, maybe there. And maybe here.
My goodness, that's amazing.
Okay, and then I think I can show you the 2020 study is the one. This was the one that showed the liver angiomyolipoma. This big lesion here, which again, Sudhakar thought this looks like a hepatocellular carcinoma, but this was resected, and you saw the staple line on the later imaging. This was an angiomyolipoma in the liver.
Wow.
So this person's been through a lot here with these two syndromes.
Wow.
Okay.
Case of the last 6 months, David, at least.
It's impressive.
Okay.
Wow. Never heard of it. Yeah, I never heard of the combined syndrome, combined genetic abnormality. That's so interesting.
This is one of the advantages of having EPIC, because there's a lot of clinical information that comes up every time a new exam comes up to read. And so I caught these words of this contiguous gene syndrome. And so I said, well, what's that? And stuff like that. So I jotted it down and came back. So if we didn't have this information system that was displaying all this information that for the most part I am forced to ignore, I wouldn't see so many things like this. So it's really nice.
Yeah.
For discovering new stuff.
Very much so.
Those are my two cases.
Very cool.
Okay. Let's see, Howard.
Okay, let's start with this one. Let me just remind myself about this one. Okay, so here in September is a time when this person presented with, I don't know how symptomatic this person was at the time, and I can't quite remember, well, I don't know the clinical details about why the chest was imaged necessarily, but it shows these upper lung zone ground glass attenuating opacities. They were subsequently ascribed to pneumocystis pneumonia based on a positive PCR result, and I can't remember if that was a BAL or not. And then apparently, and I'm not sure exactly the timing of things, somebody decided that the patient had features, I think by history and physical exam, of Cushing's syndrome, Cushing's disease, which was subsequently shown to be the case. So Cushing's disease and pneumocystis. And then I will show you that someone took note of the fact that there is a nodule there. And let me go back now in time and try to fix that jumping around. 2020. And I'm going to try and move things around here so I can, if I can. Just bear with me a second. I want to stop the syncing here. I'm trying to move the controls aside here, and I can't move the GoToMeeting controls aside. How do I minimize this? It's really strange. Okay.
You can.
Okay.
Yeah.
I think I got it now.
Okay.
So let me go back to the nodule, and let's go back to 2020. And there it is. Now, measuring it carefully, I thought maybe it's increased by a millimeter, but of course, really, if there's any change in size, it's trivial. If there's any change at all over that period of time. And then I think that they wanted to do a dotatate scan, but there was an issue, I think, with insurance coverage or something like that. But the upshot finally was that they were looking for a source of ACTH, which was found to be abnormal. And they took that out. And sure enough, that's what it is. It's an ACTH-producing lesion right there.
Wow.
Interesting, huh?
Yeah, because most pulmonary carcinoids don't do anything.
Yeah. So obviously there's an immunostain that was employed, and yeah, he had diagnosed Cushing's and elevated ACTH. Interesting.
And the Cushing's might have been the reason why he got pneumocystis. I saw
Right.
one
Yeah.
patient who passed who was immune compromised by Cushing's rather than exogenous steroids and got pneumocystis.
Yeah. So he's had the nodule for some time and is producing ACTH. The question is, did something make it turn on? Did he have Cushing's before, but just unrecognized over time and only diagnosed now at this point in time, even though the nodule has been there for a long time? Clearly interesting how that panned out. Always something surprising. Okay, so this is how I came across this case, which is kind of interesting too. So let me go to how I came across an interesting finding. So this is an everyday post-op radiograph. See on day X, immediately post-op. And I look at that and I say, combination of, in one patient at one time, bioprosthetic tricuspid and pulmonic valves is unusual, really unusual. So of course, then I started digging further and began to find a history of extremity edema. And I can't remember the order now, but found out that the patient had that attributed to tricuspid valve regurgitation on a cardiac ultrasound. And then as I burrowed more deeply into the medical record, like David did, I saw that the patient had a history of, in 2006, what was called a colon cancer. So then let's go forward in time. So we have a patient with two valves, and I'll get back to that in a moment. And then let me see more recent imaging. me get the time right, is here. And there are findings consistent with metastatic disease in the abdomen, and presumably, of course, as well here in the subcarinal node. So it turns out that he had a neuroendocrine tumor of the appendix previously. And at the time of surgery for the tricuspid valve, the surgeon found abnormalities involving the pulmonic valve leaflets also sufficient to replace that valve as well. So we have a person, now we don't have metastatic disease to the liver because we have carcinoid heart, or findings of carcinoid heart. And most of the time we have metastatic disease in the liver at the time of the diagnosis. I went to the medical record to see whether he had a lot of flushing and diarrhea, and there was a mention of maybe intermittent diarrhea, but by description, that didn't sound like it was any kind of dominant abnormality, very typical of the carcinoid syndrome. But let's see what I have in terms of further description. So this is carcinoid heart, and there's some history there. Tricuspid valve abnormality. Here you can see the description by the surgeon, very clear that the pulmonary valve was also severely diseased. And here is a pathologic description of the valve, consistent with that. And I can't remember if I have the pathologic findings from 2006, but he had a neuroendocrine tumor with lymphovascular invasion back then. So that's a nice, interesting case. How that came to be.
That's way cool.
Yeah. Isn't that interesting? Yeah, that's how I came across it, starting with a post-op image and digging into it and getting that history. Okay. This is, to me, somewhat of a perplexing case. So here's a patient that over recent months has become quite ill, and his clinical condition has worsened. Workup has revealed pulmonary hypertension, and his clinical condition got worse over seemingly a period of months, so that he came to transplantation. Sorry about that. I got too many things mixed up here. What have I done? Let me go back. Make sure I got the right patient and all. So let's go back in time, 6/20/21, and I'll bring up alongside the most recent CT here. March, I think one of the more recent ones. So there's a person with pulmonary hypertension, diagnosed also on cath, and I would just describe these lungs as completely normal. He's got a dilated main pulmonary artery. The right cardiac chambers are a little bit enlarged, but he's very symptomatic. So what was interesting to me was that we discussed him at ILD conference, and he had a transbronchial biopsy, so a small amount of tissue. But really interestingly, the pathologist thought that she saw, even in that small specimen, maybe a capillary abnormality. So now we have the explanted lungs to look at post-op, of course. And let me make this big. And let me do this. So here are some clinical details. Shortness of breath, April 2021, diagnosed with pulmonary hypertension, function been declining quite precipitously, and pulmonary hypertension. And then we go on to look at the pathology. So here we go. These are comments from the pathologist. No distinctive gross abnormalities in our case, because they found capillary abnormality. And then here are images of the capillary proliferation. So the septa in some regions like here are very thin and normal looking, but other interalveolar septa are expanded. And let's look some more. Here you can see too many red blood cells. Interalveolar septa are expanded by capillaries that are too many. And there as well. And then we go on to, sorry about this. Oh, I just need to fix this. What am I doing? This doesn't. Here is a CD34 immunostain that shows that those are capillaries that have proliferated. So the findings here are those are capillary hemangiomatosis. And you can see the comment at least here about mild thickening of the arteries and intralobular arterioles. Plexiform lesions are not seen. And there were no findings that the pathologist could find to suggest concurrent PVOD at the same time. So a lot of capillary proliferation, but not enough to be able to discern on CT and pulmonary hypertension. It still kind of perplexes me because I would think that if this patient has so much disease, why aren't we seeing anything on the CT? It's kind of perplexing to me still. But there you have it.
It's an impressive case, Howard, given the pathology and the underwhelming imaging.
Yeah. And the patient's symptoms, it still puzzles me. And what was described as mild thickening, presumably of the walls of the muscle of the arteries and intralobular arterioles, rather than substantial thickening consistent with substantial pulmonary vascular hypertension. It's still a puzzling case to me. But that's the pathology on the explanted lungs, which is interesting. So I'll bring this up just one more time, but I looked at this so much and I'm convinced I can't find any abnormality in these lungs. Not even a hint of the smallest central lobular ground glass nodule that I can see. Just looks normal. So there you are. It's still a funny entity. I don't quite understand capillary hemangiomatosis. There are a lot of pathologists that think that the capillary hemangiomatosis is like an epiphenomenon because the primary pathology is usually thought to be the PVOD, but the pathologist didn't diagnose that in this case, which is interesting. All right, those are my cases.
Great. All right. I think that's it for today, but we have some cool stuff.
Yeah, very interesting. David, can you share that contiguous gene case?
Yes.
Via diaphragms and stuff. That is super interesting. Need to read up about that.
Okay.
All
Thanks,
right.
everyone.
Talk to you next week.
All right.
All right. Cheers.
Bye.